Started. My name is Jonna Morales. I will be moderating today's session. Our presentation is going to be, can the placenta and breast milk be used for offspring drug delivery? Should they? Before we get started, to introduce our speakers, I want to go through a couple housekeeping items. This presentation is going to be recorded and will be available through the Center for Bioethics and Humanities website. The link will be posted afterwards, so you can access it. All chats we'll go through all of those at the end for questions to ask. So please just shoot us any questions you have to the chat. Now I'll go ahead and introduce our speakers. We have Dr. Michael Zaretsky, who is a professor in the Department of Obstetrics and Gynecology at the University of Colorado School of Medicine. He is a specialist in maternal fetal medicine with expertise in fetal diagnosis and therapy. He is a fetal interventionalist at the Colorado Fetal Care Center and current director of research. We also have Dr. Teri Hernandez, who is the Associate Dean for Research and Scholarship in the College of Nursing and a Professor of Nursing in Medicine at the University of Colorado. With over 20 years at CU, she has conducted controlled clinical studies in pregnancy focused on nutrition, glucose and lipid metabolism, infant growth, and early life exposures. She completed her undergraduate training at Northern Illinois University and master's and PhD at the University of Colorado. She is an educator in the graduate school, is chair of the Anschutz Medical Campus Perinatal Research Advisory and Facilitation Committee, is an elected member of the Perinatal Research Society, and is a fellow of the American Academy of Nursing. Thank you both.
Awesome, thank you. So it's okay for me to take the virtual podium?
It is all you.
Okay, great. I can't see anybody. So hi, everybody. Thank you very much for being here today with Mike and I. We're really, I am very excited about this because really this talk is meant to be thought-provoking and really to generate discussion. And so if we can help you, give you some new things to think about and some new questions to be asking as we kind of move forward into our next era of perinatal care, then that's really our goal for today. So thank you so much for being here. So this, I wanted to acknowledge my fellow committee members, of which Gianna is one of them, on the CCTSI Research Ethics Committee. So I'm a relatively newer member of the committee, and it's been one of just such a great experience. So I just wanted to acknowledge my colleagues, Matt DeCamp, Curtis Coughlin, Brian Jackson, Gianna Morales, David Badish. We've had really great discussions, and that's actually what inspired this Grand Rounds presentation today, which we can tell you a little bit more about that. So before we get started, Mike and I just wanted to start out this presentation by really stating our intent to be very inclusive in this presentation. So we are aware that the word breastfeeding or breast milk, and I'm using air quotes, I don't mean for it to be like that, but we actually intentionally use those words. And we use them in a way that we want to be very inclusive about it. So we acknowledge people of all gender identities. We're very respectful of transgender and cisgender, otherwise gender expansive acknowledgements. And the reason that we use those words, and we used words like maternal or women in this presentation, is because we were also trying to honor the citations in the publications that we referenced, and also in the original bioethics consult as those terms were used. So thanks very much for allowing us to make that statement. So in our time together, and we do want to leave time for questions, we have a few objectives. The first is to help all of us understand some emerging challenges and also tremendous opportunities related to targeted drug delivery for not only fetal health, but maternal health and placental health. We also want to provide some perspective about the existing regulations currently that govern research in pregnant persons or those who are breastfeeding. Then we'll take a look at some risks and benefits. We have a case use application for this, but we'll look at risks and benefits to when a study drug passes to a breastfed infant. And then finally, we thought we would offer some practical strategies to help, really address these very complex ethical issues and questions that arise in these kinds of situations. Okay, so moving into our first objective, we wanted to talk about challenges and opportunities. And before we do that, I'm hoping that I can set the stage for both Mike and I moving into our time together. And so we wanted to let you know that actually this talk was inspired, as I said, by a real ethics consult that came to the campus bioethics committee. And we felt compelled to bring it to this session today because it generated such rich discussion. And really, it brought up a lot of questions, and we thought that it might benefit everybody to be able to think about some of the concepts that were introduced and some of the things that we considered as a committee. And so the case really rests on the treatment of meconium ileus before birth. And what I'll do is just kind of present the case as it came in, and then we'll return to it throughout our presentation today. So I'm going to read the case as it was presented to us as a committee. So the EPIC study was presented to us with study aims that were intended to investigate the potential of Trikafta, which is a triple therapy for cystic fibrosis, to treat meconium ileus in the fetus diagnosed with cystic fibrosis. So meconium ileus, as we'll learn about today, is a condition where the newborn's intestines are blocked by really thick, sticky meconium. And by using Trikafta, the researchers who were proposing this study hoped to find a way to improve the outcomes for a fetus and then later a newborn that are affected by this condition. So to achieve this, the study would involve administering Trikafta to healthy pregnant individuals. So these are women who are healthy, do not have cystic fibrosis, but they're carriers of the gene. And their fetus, however, is diagnosed with cystic fibrosis and has confirmed meconium ileus. So Mike will tell us a little bit more about that. But the medication would be carefully monitored for its effectiveness, like I said, in preventing or treating the condition. This particular drug therapy, ETI therapy, would continue for up to a year postpartum, and the mothers would be encouraged to either breastfeed or pump their breast milk. And that would be the mode of administration to the newborn. And the goal would be to continue that for at least 6 months, but up to a year if possible. So this research, it could be highly significant. It focuses on treating meconium ileus before birth. By finding effective interventions like Trikafta, we can potentially reduce the severity of this condition and also improve the quality of life for these affected newborns. So the study brings new hope to families that are facing the challenges of cystic fibrosis and those prenatal complications by exploring an innovative approach to prenatal care. And not only that, but fetal treatment, ultimately aiming to enhance health outcomes for these babies. So I drew us a cartoon to just kind of show the scenario of what was proposed in the study. And so essentially, I hope everyone can see my arrow here. The idea would be that a healthy mother who's a carrier of the cystic fibrosis gene, but who does not have cystic fibrosis, would take a therapy, a drug in this case, called ETI, we'll explain more, that is meant to treat cystic fibrosis, and that would reach the fetus through the placenta. And the fetus has cystic fibrosis and also has meconium ileus. Then postpartum, the drug would continue to be transmitted or administered, I think administered is the appropriate word, to the newborn through human milk, whether that is through breastfeeding or bottle feeding of breast milk. So I wanted to provide a little bit more background about cystic fibrosis because this, I think, informs some of the questions that we might ask in the bioethics space when questions like this come up. So cystic fibrosis is an inherited autosomal recessive disorder. And it affects about 30,000, 30 to 40,000 adults and children in the United States. Formerly, actually, cystic fibrosis was first described in 1938. And at that time, the life expectancy for, especially for a young infant with cystic fibrosis, was less than a year. But actually, this is radically changing because there's much better therapies available for individuals with cystic fibrosis. Essentially, what happens in cystic fibrosis is that there is a gene variation, right? And it impacts at the cellular level the sodium chloride balance or the the chloride channel. And so what this results in is a disruption in water balance that really impacts multiple body systems. It results in very thick mucus in the lungs, in the gut, other apical surfaces. And typically, if patients with those with cystic fibrosis die, it's from progressive lung failure. And often this is a result of persistent opportunistic infections. A lot of them are resistant to antibiotics. And so respiratory failure is a common cause of death. These patients also suffer from malnutrition. And that's because one of the organ systems that is impacted by cystic fibrosis is the pancreas. So they typically, persons who live with this disorder have problems with fat and vitamin malabsorption. I'm highlighting here meconium ileus for our case use today because also cystic fibrosis and this very thick copious mucus impacts the gut and the intestines. And so essentially, this new drug and the newer drugs that are out there target the pathophysiologic function as a result of the gene variation, right? So we can't correct the gene, at least not yet. But what these drugs do is very innovatively, they very specifically target those mechanisms. Now, with the advent of these drugs, and Mike and I will tell you a little bit more, this has radically changed the course of care and the life course for those with cystic fibrosis. So, people with cystic fibrosis are now living into their later years. And in fact, now health systems are planning for geriatric care for the first time for these individuals. So it's incredibly exciting. It brings a lot of hope, optimism. People can plan marriages, families, and really these new drugs, of which Trikafta is one of them, is one of these incredibly exciting new therapies. It was actually, it was approved in 2019, and the cost of this drug is about $311,000 per year. I did a lot of reading about not only the pathophysiology of cystic fibrosis, but also the lived experience of cystic fibrosis so that I could address this group today. And so a number of social scientists have performed qualitative research studies to help us understand what it's like for those with cystic fibrosis. And so I hope that I can do a small bit of justice at this point of the talk to help us understand what it's like. So people who live with cystic fibrosis report incredible fatigue, and that's mostly attributed to the work of breathing. They're also really tired because their therapy takes, on average, 108 minutes per day. So they have to stop what they're doing. There's respiratory therapy, et cetera. And it really causes fatigue. And so because of that, it's hard for them to hold down a job. And a lot of them feel socially isolated or restricted, and that's one of the reasons. Persons with cystic fibrosis also report feeling very shameful, and they're embarrassed when they're out in public. And this is because they cough a lot. And so people don't understand that they're not contagious. And so there's a stigma attached with that, particularly since COVID-19. They frequently report anxiety and depression. Like I said, many of them feel socially isolated, although on the flip side, others don't let them let that feeling stop them from being out in public with their friends, with their families, etc. They fear death every day. So that's a very strong theme that I read about. And many of them join a lung transplant list eventually when enough opportunistic infections and other problems impede their respiratory function. And this is described to them as an anguishing time period. Like I said, many report that it's hard to attend school, it's difficult for them to hold down a job. And many, as particularly younger adults with cystic fibrosis, have reported it's really hard to depend on their family for financial stability because of some of those limitations. And so this caused me to think about, you know, and others treating these patients and working with these patients in the field. What if these challenges could be overcome with better treatment? And like I said, we have these amazing new drugs that are now available. What if we could really change the life course of those living with cystic fibrosis? And so what does the future really look like in terms of targeted drug delivery for both maternal and fetal health, also placental health? And so I also did a tremendous amount of reading about sort of where we are and where it looks like the evidence is pointing to where we can head as a field. And so the idea is that what we mean by targeted drug delivery is for maternal health, fetal health, or placental health is that whatever our targeted drug therapy looks like, the idea is to target that specific, I'll say, compartment, either mother, placenta, or fetus, and then minimize the exposure to the other areas. So the idea is that if we could do this, targeted drug delivery could really revolutionize how we're able to treat not only the pregnant person, but also the placenta and the fetus. And through the development of very smart nanoparticles, it looks like this may be possible. And so these are sort of envisioned as smart systems. Now, this is particularly relevant because many pregnant women now come to their pregnancy with a pre-existing chronic condition. In fact, 40 to 60% of pregnant persons, they already take one or more prescription medications during their pregnancy. And more than 70% of those who are lactating or pumping their milk also take a prescribed medication. However, 90% of those drugs are actually used off-label. So the safety and efficacy has not been demonstrated in that sense. And so when these situations arise, you know, often as providers and practitioners, we're having to weigh the balance between the health of a pregnant person and versus the fetus or with the fetus, and we weigh them against each other when medication is needed. So there's several exciting developments. I wish I could spend a lot more time on this, but there's several exciting developments in the field where maternal and or newborn conditions or conditions of the placenta may be treated using these nanoparticle smart drug systems. And they include bacterial vaginosis, diabetes, hypertension, preeclampsia, fetal growth restriction, and also premature rupture of membranes, and also preterm birth. And so, like I said, the idea is to very specifically target where the therapy, or what the drug would reach, and then minimize exposure to the other areas. And so this kind of the scenarios, when I was thinking about this, could be the following. The drug is administered, but it remains only in the maternal compartment, and it completely restricts fetal exposure. Another scenario would be that the drug, as I said, targets the placenta, but then it also restricts maternal and then fetal exposure. Or, hopefully you can all see where I'm going with this, the drug targets the fetus and then restricts maternal exposure. And then finally, the drug would target the infant through maternal exposure. And I was thinking about in the sense of breastfeeding and the postnatal impact. Now, there's a lot of considerations, and there's a lot of considerations, I guess I would say, in terms of the success of these smart systems and what that would look like. And so I've listed some of them there, here on the left side. There's maternal pregnancy adaptations, mother's metabolism changes. There's the diffusion distance. Here, I'm gonna show you a picture here. So I have one kind of cartoon here, just kind of showing you, if you let your eye follow kind of from top to bottom of this figure, this just demonstrates the layers that a drug would need to pass through in order to reach the fetus, like through the placenta. And so that diffusion distance of whatever the particle is important. Gestational age, nanoparticle size, like how big the particle is, impacts its penetration of the placenta, its impact on the fetus, and also the charge of that particle, its stability in blood. You can read these with me, but the intracellular uptake, hepatic clearance, renal clearance, barriers. Barriers such as mucus. Like I said, the integrity of the placenta, the placental barrier. And then when you consider the mammary gland itself, its integrity, lactation volume. Anyway, I wanted to list all of these things, and it might seem a little bit daunting. And so we have made some progress in animal models, but this is kind of where we are in the field, and these are the issues that are being considered by those developing these therapies. And then a relevant consideration for us today is the idea of nanoparticle toxicity. And so whether it's ETI therapy or whatever the medication is that's administered to a pregnant individual, even with whether it's these smart therapies or those drugs, there are toxicity possibilities, risks for that, and they need to be considered, in this paradigm. So at this point, I am going to turn the virtual podium over to Mike.
All right, thank you for having me. I wanted to take a little time to go over fetal therapy. This is going to be the quickest fetal therapy lesson ever. We can divide it up into three categories: invasive, minimally invasive, and non-invasive. We'll go to the next slide, please. And this is an example of invasive fetal therapy. This is a in utero or prenatal repair of the myomeningocele. And this is very invasive. It requires a laparotomy. The uterus needs to be open, and we expose the baby in order for the neurosurgeons to repair the myomeningocele defect. And this is actually a procedure done not for survival benefit, but for improving the morbidity in these kids with spina bifida. Next slide, please. And this is an example of minimally invasive fetal therapy, a common procedure we use to treat twin-twin transfusion syndrome by ablating the anastomoses. You'll see this laser taking out this vessel here. In the case of twin-twin transfusion, this requires a small fetoscope into the recipient twin sac for this therapy. Next slide, please. And then the therapy that we're discussing today is non-invasive fetal therapy, primarily transplacental. And this requires no access to the fetal compartment. So we're not talking about needle procedures like intraperitoneal injections or intramuscular injections, et cetera, but medications that we're giving to the mother in order to benefit the fetus. Next slide, please. So these are common. I try to come up with common uses that we do in obstetrics. And one of the most common is we give the mom corticosteroids or betamethasone for fetal lung maturity. We use RhoGAM to prevent maternal immunization, to prevent fetal anemia. We use folic acid to prevent neural tube defects. We provide vaccinations during pregnancy to provide passive immunity to the fetus and the neonate. We use magnesium sulfate given to the mother to provide neuroprotection to reduce cerebral palsy in babies born prematurely. We commonly use antibiotics to improve fetal and neonatal health, and also reverse hydrops for congenital syphilis. Next slide. More uncommon uses, we use immunoglobulin and corticosteroids for neonatal alloimmune thrombocytopenia and early onset fetal anemia for alloimmunization, and also to treat fetal congenital heart block. We commonly use antiarrhythmics for fetal tachyarrhythmias, including digoxin, flecainide, and sotalol given to the mother. And a little bit more controversial topic is use of corticosteroids in the setting of congenital adrenal hypoplasia that prevents female external genitalia masculinization. Next slide. We also use steroids to reduce the size of very large congenital lung lesions. We use maternal thyroid medications when we diagnose a fetal goiter. We actually use non-steroidals like indomethacin to improve the outcome for a circular shunt seen in Epstein's anomaly, and we use Solendec, another non-steroidal, to actually reduce amniotic fluid in certain settings with polyhydramnios or too much amniotic fluid. Next slide. We also use mTOR inhibitors or sirolimus for large fetal cardiac rhabdomyomas and lymphovascular malformations. Bisphosphonates are used in the setting of fetally diagnosed generalized arterial calcification of infancy, or GACI. And we can supplement the mother with vitamins in the cases of fetally diagnosed inborn errors of metabolism, and use high-dose antivirals in the setting of congenital CMV. Next slide. Now, as far as ETI, we talked a lot about this 3-drug combination called Trikafta. It uses 2 drugs, elexacaftor and tezacaftor, which actually helps cellular processing and trafficking of the CFTR protein. It brings more protein to the cell surface. And then ivacaftor potentiates gating of the CFTR protein at the cell surface. And Teri mentioned that there were 2 studies that came out in 2019 showing remarkable benefit for patients with cystic fibrosis. And it's now approved down to age 2 years and above back in 2023, a year ago. And now 90% of cystic fibrosis patients are eligible for this therapy, and it's having remarkable effects. Next slide. Now, as far as ETI in pregnancy, there's an ongoing study called the Mayflower study, or Maternal and Fetal Outcomes in the Era of Modulators, that's tracking cystic fibrosis patients who take ETI while they're pregnant. And it's showing that there is so far no known adverse fetal outcomes. There are some concerns of the development of cataracts in newborns, mothers who take this during pregnancy, which have been very mild. Next slide. Now, as far as meconium ileus, the data revolves around animal models and human case reports. Meconium ileus occurs in 20% of newborns, of mothers, or of newborns with cystic fibrosis, and there's good data showing that those born with meconium ileus have worse outcomes, higher morbidity compared to those that were born without meconium ileus. In the ferret model that has cystic fibrosis, ivacaftor was able to prevent intestinal pathology in utero and preserve pancreatic function. And the male kids were born with preserved vas deferens, which is usually absent in males born with cystic fibrosis. Next slide. And this is a case report of a mother with cystic fibrosis who continued ETI therapy throughout pregnancy. Her newborn also had cystic fibrosis, but was born with a false negative newborn screen for cystic fibrosis, also had normal pancreatic function and lower than expected sweat chloride levels. And during the pregnancy, the fetus had echogenic bowel, which is a sign of meconium ileus. And at 32 weeks, this had resolved during the pregnancy. Next slide. And this is a case of a carrier patient. So the patient herself, who was pregnant, did not have cystic fibrosis, but her fetus did. And the fetus was diagnosed with meconium ileus at 28 weeks. And this patient requested that she wanted to be started on ETI therapy, which was started at 32 weeks. And by 36 weeks, the bowel dilatation, the signs of meconium ileus had resolved. And after delivery, there was no evidence of meconium ileus. She continued ETI therapy while breastfeeding, and the neonate had preserved exocrine pancreatic function at 2 weeks of age and lower than expected sweat chloride levels at 1 month of age. Next slide. And this is another similar case where a meconium ileus was diagnosed in utero in a carrier patient, started on ETI therapy at 31 weeks, and there was resolution of findings by 39 weeks with no evidence of any bowel issues after birth, and the mother continued during breastfeeding as well. Next slide. So we talked a little bit about the original study consideration, and the main point was to do a pilot study with 10 patients who would have to be a carrier mother whose fetus was diagnosed with meconium ileus. And the aims of the study was to evaluate the safety and tolerability of ETI therapy, and then to evaluate the effect of maternal ETI therapy on suspected meconium ileus in utero, and then evaluate the effect on the pancreas in newborns with cystic fibrosis. We had one exploratory aim, which was to assess the concentrations of ETI in relative maternal and neonatal biospecimens, including breast milk. Next slide. So the patients were to start on ETI prior to their 30th week of gestation and to continue breastfeeding for up to a year. And this study was actually first presented to our fetal therapy society called the North American Fetal Therapy Network, or NAFNet, which has a scientific review committee. And the study was well received, except one question drew attention. And that question was whether or not it was appropriate or ethical to give a mother who derives no benefit from the drug to give it to the mother for the purpose of breastfeeding to provide therapy to the newborn. The newborn, again, this drug is only available for ages 2 years and above, and hence the reason for the consideration of breastfeeding to provide the medication to the newborn. As a result of this question, I sent this on to bioethical review, which was subsequently completed by this group. So I'll give this back over to Teri.
Awesome, thanks. So, okay, so next, our goal is to at least provide some context in terms of the existing regulations for research for those who are pregnant or lactating. We couldn't include it all, but I tried to include enough that would give us some landscape on which to formulate our discussion. So it turns out, I actually did a lot of reading on this as well. And I've been part of Panel C on the IRB for about 10 years now. And so my impression working in my own research in pregnancy, also being on the IRB, working with the FDA, is that there's a lot of considerations with studying pregnant women and neonates. We've had to overcome some of those challenges over the year in my own work. Reading in the literature, there's many published reports, reading on federal websites, NICHD, et cetera. It turns out the federal regulations actually are incredibly supportive, and the FDA both. They're very supportive that pregnant and lactating persons be included in clinical trials. And there's many reasons for that, some of which are illustrated in this figure. And I was surprised to learn for myself that only 9 drugs out of all the drugs available, only 9 have been approved and marketed in the US specifically for obstetric complications. And so pregnant and lactating women and neonates are often included in a category or in a terminology I hadn't heard before called therapeutic orphans. And that's because because drugs and therapies are underdeveloped, pediatrics and children fall into the same category. They don't have access to the same benefit as those of us who where the therapies are validated and efficacy has been demonstrated. So, so this is a large reason why the federal government and the regulations continue to change over time. Sort of the history of this, and there's many things I could bring up, but I mean, the one of the biggest black marks in the history of a therapeutic drug given to pregnant women is what's commonly termed the thalidomide tragedy, which it happened in the 1950s. Essentially, thalidomide is a sedative, and it was administered in the late 50s to pregnant women to help control nausea and vomiting. And so unfortunately, I think we've maybe all heard about this in the bioethics space, but that resulted in a tragic number of fetal malformations. And so this is really kind of the start of when pregnant women and lactating women specifically earned the title of vulnerable in terms of clinical research. And this prevented their participation in phase 1 and phase 2 clinical trials, particularly starting in some regulations that were enacted in 1977. Now, in 2012, there was actually the regulations started to change. And so in 2012, the FDA passed the Safety and Innovation Act, and this mandated that pregnant and lactating women and infants be included in drug trials. However, the mandate didn't require pharmaceuticals to develop those drugs. So most of what the landscape currently is that really we haven't made much progress. Even though the federal regulations have there's been an attempt to shift them to, as I said, to promote including pregnant women and neonates in clinical research. Now, ever since the thalidomide tragedy, and due to other instances over time, pregnant women and neonates and children have been deemed vulnerable. But just in 2018, very recently, the 1991 Common Rule was modified. So remember that the Common Rule is sort of the federal policies that we follow for the protection of human subjects. And before 2018, pregnant women and neonates were considered vulnerable. But as of that new update, the modification to the Common Rule, that removed the classification of vulnerable as it pertains to pregnant women, And so even with that, in the year 2024, the flavor of what's published and where we are as a field is that we've made very little progress in moving forward. And so just a little bit more context so that we can move into our discussion here shortly is I wanted to just present, the criteria that we consider on panel C at Comer when studies come to us that include pregnant women and a fetus and or a newborn. What constitutes approvable research? So I wanted to just sort of present this to you for your consideration. So on the left kind of panel here, this is what we are asked to consider as IRB members. If pregnant women and the fetus are to be included in a research study, the following must be true. There cannot be any inducements, monetary otherwise, to be offered to terminate a pregnancy. And individuals engaged in the research can have no part in the decision as to the timing, method, or procedures used to terminate a pregnancy. And individuals engaged in the research will have no part in determining the viability of the neonate. And then the final consideration, so all of these have to be true. Any risk to the fetus from the research is the least possible for achieving the objectives of the research. And then in terms of risk assessment, that's kind of a second part of our consideration as IRB members. There are 3 criteria here, and the first one has to be true, that there's potential benefit to the pregnant woman or fetus, and the risk to the fetus is caused solely by interventions or procedures that hold out the prospect of direct benefit for either mother or fetus. So essentially, there has to be potential for benefit, or there's no potential for benefit to the pregnant woman or fetus, but the risk to the fetus is minimal, not greater than minimal. And the purpose of the research is to develop important biomedical knowledge, and it can't be generated by any other means. So A has to be true, And then B and C also, or B or C must be met. And so, some of the, moving into kind of our last objective here, the risks and benefits when a study drug is passed to the human infant. Okay, so we wanted to use ETI therapy for cystic fibrosis based on our case that was presented to us as kind of like a case example for this discussion. And so remember that in this scenario, in the study that Mike was involved with, and the consult that was submitted to the committee, it involved administering ETI to a healthy mother, but the fetus has cystic fibrosis confirmed and also has meconium ileus. And so we can look at the potential benefits to those. These are benefits of ETI therapy to those with cystic fibrosis. And so this is going to come from the space, 2 years of age or greater. These drugs have resulted in radical life changes for those living with cystic fibrosis. Not only a reduction in cough and mucus, but what patients report who've taken the drug is that it's called the purge. It comes on so quickly and they are able to, for the first time, clear mucus from their lungs, kind of in a whole body system way. They've never experienced that before in their life. So it's very dramatic in some patients who take ETI therapy. There's fewer pulmonary exacerbations, fewer hospitalizations, improved lung function. I also read some qualitative research about the lived experience of taking these drugs, and patients report increased optimism, quality of life, they can plan families, their nutritional status improves. Also, Mike mentioned the absence of the vas deferens in male fetuses born with cystic fibrosis. Can we prevent that? So we heard some evidence of that in the case studies that Mike presented. A potential benefit could be reversal of meconium ileus. Persons with cystic fibrosis after initiating ETI therapy have gone on to hold jobs. They're able to attend school. They can marry. They can plan families. So those are some things to consider. But there's potential risks. And again, how do these risks apply to a healthy mother? I think that's one of the questions that we might ask in this space. So there's potential risks to also consider. There's formation of cataracts. Actually, one of the biggest challenges with ETI therapy is that it causes difficulty sleeping and frank insomnia. Hypnagogic hallucinations, which are kind of those weird sort of hallucinatory dreams you have when you're not quite fully asleep. Actually, those can be exacerbated, that experience, while taking ETI therapy. Patients also report brain fog, reduced concentration, attention, memory difficulties. They have trouble with word finding puzzles. They have trouble when they're speaking to find words. They report confusion, mood and perceptual changes, and also anxiety and agitation. And in fact, I read one report that that said that up to 24% of those taking ETI either need a dose change, or some of them, these symptoms are so dramatic that they can't take the drug at all. And so in our last part, hopefully I left some time for questions here. We thought we might offer a couple of strategies to think about in how we handle when these very complex questions come up. And so the first thing I would offer is that any of us can think like an IRB member. So, the information is publicly available on our COMERB website. Anyone who emails me, I would be happy to help you find them. But also this slide right here kind of shows you what I did earlier. And so strategy one might be to think like an IRB member, and you can ask yourself the questions with your study team. Is this approvable? Or do we think that, can we make the case that this research would be approvable? So remember that in order for it to be approvable, for pregnant women and a fetus to be included, there can't be any inducements to terminate the pregnancy. So in this situation, I would say, yes, we meet that. Those engaged in the research can have no part in the decision about terminating a pregnancy. Yes, we meet that criterion. Individuals engaged in the research will have no part in determining viability of the neonate. Yes. And then this last one, any risk to the fetus from the research is the least possible for achieving the objectives of the research. Do we know that? I would say that's one question I would pose to this group. And then in terms of the risk assessment, is there potential benefit to the pregnant woman or fetus? I would say in this case, yes, potentially the fetus. Is there potential benefit to the pregnant woman or the fetus, but the risk to the fetus is not greater than minimal? Do we know that? I would pose that question to this group. The case reports seem favorable, but do we know that the risk would not be greater than minimal? And the purpose of the research is development of important biomedical knowledge. It can't be generated any other way. That might be yes. That would be another question that I would pose for this group. Other considerations, kind of when strategies that we might offer when these complex questions come up is think about kind of the caliber of the science. So one of the things that we talked about as a committee when Mike submitted this, this really interesting question to us is how will the dose of medication be administered? Like, how do we know what the dose is? How do we know what the dose is that would reach the infant? Remember all those layers that the particle, that the drug would have to pass through. So in terms of caliber of the science, how would the investigators know the quantity that reaches the fetus or the infant? And then in terms of potential risks, as I said, not all persons with CF respond in a robust manner to ETI therapy. How do we know that this fetus would be a responder or not? What if the medication alters the newborn sleep pattern? So insomnia is actually a very large concern in those with taking ETI therapy. And in a newborn, I think we all can appreciate this. The newborn sleep pattern is critical for neurodevelopment, for neurocognitive function, and that developmental trajectory. Might the drug alter that trajectory? We don't know. I think that would be another question to consider. And as I said, how do we know that the fetus would respond? Another question that we considered as a committee is, who is the research subject? I actually forgot to add that to the slide, but that was a very big consideration by the group. So in this case, the fetus seems to be the clear intent for benefit. Is the mother then a healthy volunteer, as would happen in other clinical research? So there's different ways that you might view that. And then other practical kind of considerations as you're thinking about this are the four primary bioethical premises, right? Which is beneficence or doing good, non-malfeasance to do no harm. Remember that delicate balance. Autonomy, which has to do with giving a person the freedom to choose freely, and justice in ensuring fairness. So typically something that would not come up in our discussion as an IRB member, but maybe it's important today is, you know, the cost of this drug is over $300,000 a year. Would there be fair access to the drug? I mean, so that might fall under that justice category. And so that is my last slide, but I would love to maybe stop sharing. And then if there are questions, I have a number of questions I could pose to the group, but it would be great to spend some time getting your thoughts, and so we can talk together. Would that be okay, Gianna?
Yeah, I think that would. Yeah, if anyone
Great.
has any questions, please send those to the
Oh,
chat.
I can see you all.
Great. Yeah, thank you. That was super. Thank you both. That was extremely thought-provoking. One question I was thinking a little bit for you, Dr. Zaretsky, as a PI, but then also Teri in your role as a researcher and on the Research Ethics Committee is what responsibility do investigators have to question the ethics of a different experiment being offered to, or a different clinical trial being offered to them outside of considerations already taken by institutional review boards?
No, I just, Gianna, I'm sorry, do you mean like participation in more than one trial? Is that what you're?
Well, yeah, let's say this is centrally received institutional review board approved at other places. You know, what is on Dr. Zaretsky to consider if he wants to bring that now to UC Health as well?
It's a great question. The goal of this was to get a central IRB at UC, and then expand it to other centers for participation in the trial. And this would have been a investigator-initiated industry-sponsored trial, which interestingly, just to give you follow-up on this, Vertex Pharmaceutical that makes this drug was very interested in this topic, but chose not to fund this trial. And so when we talk about justice and fairness, I think they fell very far short on this. And that's a whole different conversation. So now we're doing a registry instead of a pilot, because what's happening is the CF world, it understands that this is a thing, that pregnant patients who are carriers can potentially take this drug, and they're finding ways to get drug approval, even though this drug costs $300,000 a year. And we've already had 3 patients locally within the last 6 months who have taken ETI during pregnancy. And I've talked to several investigators around the country who are also having patients take this drug. They're finding ways to get on it. So we're going to collect this data in a registry that's going to be IRB approved locally. And again, there'll be data use agreements, et cetera, for other centers to submit data to. I don't know if that answers your question or not, but that gives you follow-up on where we're at currently.
So I think that is so great, Mike. So one of the other kind of components that was part of what Mike and his team went through is that they were unable to find kind of a case precedent. So there were those case studies, but we couldn't say, oh, there's these other institutions or these other studies going on, Mike, if I'm correct with that. And that actually happens. Is that correct?
Yeah, there was no precedent for this to give a mother a drug to purposely give through breast milk to the child, which was a surprise to me, because in my mind, we do all the transplacental therapies, and I'm thinking about this, like, makes total sense to give the mother the drug through breast milk because we're doing it transplacental. Why wouldn't that be okay? And I was kind of surprised that there was no precedent for it.
Yeah. That's kind of, you explained it better than me, but that is something that we ask, as an IRB, frequently, I guess I would say.
Yeah, I think all the considerations for already used, probably run-of-the-mill medications for placental delivery in light of not having anything for breast milk is a really interesting comparison. Do you see any other studies on the pipeline for a similar method of delivery, or is this being talked about on a bigger scale?
Are you talking after delivery?
Yeah, breast milk.
No, I'm not aware of it. And again, I was surprised that there was no precedent for it. And I learned quite a bit through this experience that one of the most common question was, why don't you just give the drug directly to the infant? Well, the whole reason the breastfeeding came up was that the drug's only approved down to age 2. And I would expect manufacturer Vertex would not allow that drug to be released for that purpose until further studies are done.
I think from the federal government kind of standpoint, there was actually a task force years ago. It's good that I did this because I actually wasn't aware of this. But there was a task force years ago convened to suggest recommendations for this very reason, in terms of expanding, in terms of encouraging the inclusion of pregnant women, neonates, lactating persons in clinical research. And one of the big pushes in those, there were 15 recommendations, so without getting into the weeds, one of the big pushes that came from that is the support of registries. Which Mike, I think, I believe there might be a registry in process here, there, but so that might be one way, Gianna. You know, again, it would be observational data, I would say, in that sense, but that could actually be very powerful in terms of, you know, pooling data across centers to better understand the effects, I guess, is what I'm getting at. Mike, I don't know if you want to add.
No, that's good. There's a great question in the chat. I just wanted to.
Oh, sorry, yeah.
Yeah, you were just kind of getting at it a little bit, Teri, but how does a lack of precedent affect the ability to do a clinical trial when precedent has to come from somewhere?
Yeah. You know, typically, there's a heavy focus on preclinical data, in animal models. Well, in animal models, I guess, or cell therapy, you know, it could be, so anything preclinical. Yes, that there's a heavy focus on that, by the FDA and others.
Well, thank you both again. That was a wonderful talk, very thought-provoking, and it will be available on the Center for Bioethics website later. I also want to mention that our next Ethics Grand Rounds will be on June 13th with Dr. Micah Hammer discussing physicians' conscience-based barrier to medical aid in dying, and we're going to have Dr. Arthur Kaplan as a respondent. Thank you both again, and I hope everyone has a great rest of their day.
Thank you.
Thank you.